Good morning, and we're delighted to welcome you here for the 30th annual EACTS meeting. I'm here filming a roundtable for CTSNet on the topic of implementation of evidence-based practice for allied health professionals. My name is Jill Lay. I'm a clinical nurse specialist at California Pacific Medical Center in San Francisco and a clinical professor at University of California, San Francisco. I'm joined on the panel by Christina Bannister, an advanced nurse practitioner at Southampton in the United Kingdom, and also our nursing and allied health representative at the Society of Cardiothoracic Surgery in the UK. I'm also joined by Richard Van Valen, who's an advanced nurse practitioner and a PhD candidate in Rotterdam. Welcome, both of you. And to start this off, I'd like to just begin with asking each of you to give a brief definition of evidence-based practice and how you translate that for your nurses and colleagues.
Evidence-based practice in the nursing world, we look at obviously the research based around all the topics that we're looking at. For example, especially with sternal vests after cardiac surgery, it's really important to make sure that everybody knows the basis of good sternal wound healing, and there's lots of different types of vests and jackets out there, and we look at the evidence and all the theory behind how those work, and obviously we can use the best vest for those patients.
Good. Richard.
Well, evidence-based practice for me is something like the Holy Grail. Everybody mentions it, everybody says they're working according to evidence-based guidelines and practice, but in reality, the biggest problem is that nobody really can tell me why they're doing stuff. And evidence-based practice should be that everyone who does something is able to tell me, well, that's the reason why. We saw some guidelines, we have written some reviews, and now we think this is the best possible intervention for that patient. It's evidence-based, and we can show you how it's based.
Excellent. And I think today at the meeting we've had excellent examples of that in the allied health sessions. We had numerous presentations, and one of the things I really appreciate about nurses and colleagues that take on holy grails like sternal precautions. So we heard a fantastic session about when you should be able to drive, something that we've arbitrarily said was 6 weeks, but we heard some great information yesterday that it's not really 6 weeks, it's really an arbitrary decision, and a fantastic researcher from Melbourne has really gone after the evidence to really look at it in a very interesting way.
And it was done so very practically. They really got patients sitting in a driving simulator and having them make the motion of closing your seat belts and driving backwards, and then they used ultrasound to see do those sternal edges move. It was, for me, a very practical example of evidence-based practice, and I was also, like you, very impressed by the research done.
Yes, it was an outstanding meeting.
Absolutely, and it's something that we can translate into our practice every day when we're looking after patients. We talk to patients about what they should do pre and post surgery, and driving is really important, especially for all the patients. So when we have this evidence and we can use that and translate it into the care that we give for our patients, that's exactly what we want to be doing.
And on the other hand, if I can elaborate a little bit more, on the same session you saw how difficult it can be. We had Marije de Lange from Nieuwegein, who did an excellent research project on bacteria. Sorry, I'm Dutch, so I'm not quite sure if I said it correctly, but a positive urine sediment in patients preoperatively, and she showed quite convincingly that you shouldn't need to treat those patients. It would be safe to operate them without antibiotics. But getting that knowledge implemented in reality is so difficult. She told me that even in our own hospital, it's quite a bit of a battle uphill to get that information to the surgeon and then translate it into actual policy in real life.
I think that raises another really important question. How do you engage your nursing staff? I know in our own organization, sometimes people can be a bit turned off by research if it's not something that they do every day. So how do you get your staff involved with things like that?
I think it's really important to get the staff involved. If you can show the nurses and the staff that you're working alongside, this is what you're saying to patients, this is the information you're giving, and this is the reason why you're doing it. That really helps them to implement the research. They are quite engaged if you can give them reasons why. A lot of nurses say, oh, we've always done it like that, why do we need to change? And evidence changes over time. So it's really important to keep up to date. And I think most nurses are quite good at it. It's following on from the bacteremia sort of discussion just now. It's also helps us with our surgical colleagues, because when you have patients who are maybe are going to be cancelled because they've got a bacteremia, this research really helps to sort of talk to the surgeons and say, actually there's research that shows this X and Y, and we can really promote the sort of the patient care and make sure patients aren't cancelled for surgery.
Exactly. And how do you get your staff engaged?
Well, it's very difficult, and it's the same in every hospital, I think, and people say, well, we've always done it like that. I think it's very important for those daily questions that everybody asks to get them involved, to try to get them to do their own research and to help them, to get somebody with a master's to help a couple of staff nurses to find evidence and to read those articles and say, well, this is a good article, this article is a little bit less of quality and this is the reason why. And then have them write their own guidelines based on the knowledge that is known. For example, we've had discussions for more than 10 years with your IV lines. Should you flush them?
Correct.
On a daily basis? The discussion arises every time we have a new nurse on a department. He says, well, in our department, we used to do it like that. And that is why it's so important to engage your nurses in the things you do. Have them be a part of a research group in your hospital. Have them make some research questions and help them answer those research questions. It's always easier if they are involved than when it's somebody up high in the hierarchy or a national society, even an international society who says, well, you should do it like that.
Yeah.
People will say, yeah, but we always done it like that and we will keep on doing it like this.
Yes. And I think you've pointed out the key first step is to ask the question.
Yeah.
Is to ask a question that interests you, that people don't know the answer to, or that there's literature that's recently come out indicating that we're doing things differently than we should be doing. And then the other, I would just ask for a couple of examples of things that you've seen your staff get excited about when you've done these sorts of projects, beginning perhaps just with explaining the literature to them.
So probably, as I mentioned right at the beginning, one of the key aspects for us was probably sternal vests. Sternal vests we use post-cardiac surgery. They help support the wounds, especially in larger patients, diabetic patients, and there's lots of different types. And that's the problem, is what do you use? Which ones do you use, which are better? And the more research that comes out on the new papers shows us the evidence of actually are they worthwhile wearing? Do they help with sternal stability? Do they help with reducing surgical site infections? And long term, do they help sort of the patient have those? And it's been quite interesting. We've introduced a new, at Southampton, we've introduced a new sternal device that we've been using for our patients. The patients quite like it as a whole. And the nurses are all now used to fitting them and putting them on. And they can see the research that shows that actually having a sternal device, although it's expensive at the beginning, does help reduce the infection rate and also holds that sternum together, and therefore you're not having the patient being readmitted to hospital, which adds cost and obviously discomfort to the patient, and also helps them not to have any problems post-cardiac surgery. And in fact, patients now we found who don't have one, because we have a strict criteria of who has the jackets and who doesn't, they say, why haven't I got a jacket? I would like a jacket. Why has that person got one? Can I have one?
Exactly.
And the patients are so really keen because they think anything they can do to help themselves, and they're just as keen to learn the evidence behind, all the research and things and how their sort of heart surgery is progressing, as much as the nurses and the doctors.
So some good examples from our hospital are one who had an amazing impact on the amount of infections that we did. Just in the turn of the century, we did a large research on mupirocin in the nose to prevent nosocomial infections. That was from our center. Nurses were involved, and that was one of those things in which we saw an enormous reduction in the amount of infections. But even today, we try very hard to have them involved and to try to find things that can improve outcome of patients. So we had nurses on our research staff who researched the possibility of closed wound negative pressure therapy. So when you have your wound closed in theater on a sterile field, then you apply a negative pressure therapy on your closed wound to prevent infections, with some very impressive results. But also at the moment, that's something that's a very big discussion within our hospital and people are working on. How long should people lie on their back after surgery? How difficult is how troublesome is it if people turn on their side after a couple of days? I personally think it shouldn't be a problem. If it's a stable sternum and people don't have any pain, they should do it. But our surgeons say no, people should lay on their back for 6 weeks. And the truth probably is somewhere in between. but getting the evidence is our current challenge.
Yes.
Thank you very much.
Well, and I think our Melbourne researcher will be able to add some information to that.
And I'm quite sure she will say no 6 weeks.
Exactly.
No, definitely
exactly. And I think you brought up a couple of issues I'd like to make. Number one is pain. It's such an important variable for all of our patients, and trying to get the best practices out there that we possibly can. I had an opportunity to work with a fantastic researcher in San Francisco, Kathleen Pintillo, and we did a comparison of a non-steroidal versus a narcotic as a pre-medication for chest tube removal. And we found actually that both medications worked quite well as long as you gave them time to work before you removed the chest tubes. But I mention it because it was one of the projects that really got our nurses engaged. They saw how we were doing a double-blind study. They were directly involved in it. It was nurse-driven research.
Excellent.
There was a sensory component to it, so they read a script to a patient. Some got the script read about what you're going to expect in terms of senses, feeling, seeing.
Fantastic.
The other group did not get that, and that made a difference as well. So it was, getting staff involved on any level, I think is really very helpful to just convey to them it doesn't have to be a huge project. The other thing that you mentioned is finances. Sometimes we need to get funding for these projects that we're doing. How do you go about getting the support that you need to get the funding to move your projects forward?
Funding is a huge issue for everyone. It's very difficult to get that support. We have had support from the universities that we're linked with, and obviously work together with the universities to help some of the projects. And projects that obviously are related specifically to a company, then the company's worked as well with the hospital to try and fund some of these projects. But it's a massive problem. You want to try and produce good evidence-based information. You want to try and prevent a conflict of interest with the company that maybe that you're working with. But obviously, the companies are the paid people to help sort of support, especially in the UK where money is so tight at the moment. Then the companies are the people to go to help support that research to get the evidence so that we can move things forward.
Funding in the Netherlands is also a problem. I'm very fortunate that we have a university who acknowledges the importance of allied professional research. So they have a grant they give out every 2 years, and 5 people can win a grant from 50,000 euros to 200,000 euros.
That's good.
And that's pretty much meant for 1 to 2 years of research that you can buy yourself some free time for your daily jobs. And I've tried to win one. I didn't win. There were some excellent research proposals, but I think that's a start. And in the Netherlands, there are some private persons and companies who give some room for financing of studies, but it's difficult, especially for the allied professionals. So we still have a lot of work to do there, but I think like today we are on EACTS, they have an allied professional day, and that's the start, showing that we do important research, showing that our research has an impact on your daily practice and has an impact, even more importantly, on your patients, is a start to make everybody aware of the importance of evidence-based practice for nurses, allied health professionals, and to make sure that everybody can get some funding if they have a good research proposal.
And I think it's really important as well to note that the Allied Health Professional Programme here at EACTS promotes nursing and allied health professional research. As the medical staff, as the doctors, they are expected to do research as part of their work. But in nursing, that really doesn't really exist. Nurses come to work and just do a job. And I think it's really important that when we are leading nurse-led projects, to get the junior nurses involved, and then they can themselves see, actually, there is a benefit from this, for myself, for the trust, for the whole of nursing, and for the patients. And it's really key to sort of move that forward. And I think when people come to various conferences and see the nurse research that's gone on, that promotes it all.
Yeah, I am very impressed with the abstracts that have been presented at this meeting and the Society of Cardiothoracic Surgery in the UK as well. And I think it's something I would really emulate as the Society of Thoracic Surgeons meetings in the United States move forward. It's just been a really fantastic opportunity. In the States, there are nursing societies that provide grants. The American Association of Critical Care Nurses is a big supporter. And one of the things that I'm really pleased with that they've done is they have the big big research grants that you mentioned, but they also have smaller pots of money for nurses that want to do small tests of change. So for example, we're looking at a project right now with some of our pulmonary and other surgical patients to determine which ones of those actually need a Foley placed at all. We talk about reducing catheter-associated urinary tract infections. If you never put a catheter in, you will not get a catheter-associated urinary tract infection. But it's something that our nurses are interested in, very small test of change. We're just, going to look at trying to use a flow
Very
chart,
practical, yeah.
bladder scanners, and really determine if we can come up with an algorithm. And others have done this work. We'd like to emulate it. So I think that's the other thing, is just starting with an idea. It doesn't necessarily have to be something that you thought of yourself. Repeating others' work is just a tremendous opportunity, and I think something that can get all of our nurses excited. And so sort of one other question that this leads us to, now that you've done all this great work, how do you spread the word? How do you get it out there?
There's lots of ways of getting it out there. In the UK, obviously we use the Society for Cardiothoracic Surgery. We have a website. We have allied health professional and nurses pages on the website. The last year's meeting, all the presentations that took part in the Cardiothoracic Forum, which is the nursing and allied health professional stream, we filmed all of those. And then we put all those onto the SCTS website, so that when we go onto the education pages and link to the nurses page on that, you can see every single presentation that's gone on. And that's great, because if you can't, nurses struggle hugely to go to conferences. It's not seen as something that's beneficial, which is a real shame. And I think that the networking that you get at a conference like this one is invaluable. So often nurses can't go. So having those presentations where they can download them and have a look at them and watch them and learn from them is really, really valuable. And also, I've found that when I've gone back to my trust and I've said, I went to like EACTS and I saw this fantastic presentation and I think we should do this. It's a really good innovation. It's something that's really simple. We could maybe start this in our trust, and it will save money and reduce the length of stay. To have it filmed and to have that where you can show your managers is excellent, exactly. Because they themselves can see that, and they can also see the benefit of going to the conference, all the network opportunities that go on.
Did you want to add?
No, just short. There are options to get your articles published in good scientific magazines. The amount of scientific evidence that trickles down to the work floor is very limited. So I totally agree with Chris that it's very important that you give them an opportunity to view the presentations. It would be great if everybody could come to EACTS, but that's not a possibility. So the other thing we're working on together with CTSNet is getting a couple of our presentations on CTSNet, so people are able to see what we do here, what the innovations are, what the evidence is behind it. So that's very important, and I think it's important that if people read something somewhere, that you take them seriously. If one of the junior nurses come to you and says, well, I read something, I think it's very vital for our department, take them serious, take the time to sit down with them, look at the article, say, well, I totally agree with you on that point, but that is the weak point in the science, and try to get them involved at every level of your department.
Absolutely, and in terms of spreading the word, CTSNet is a tremendous resource for this. If you haven't yet checked out our Allied Health portal, these two have been very involved in that effort, and we have some fantastic articles, protocols. We were really hoping to create an informational source for true evidence-based practice, that people could share the work that they're doing. They can share the projects that they've worked on. And for example, at this meeting, the networking opportunities are just so amazing. To hear the work on sternal precautions, we've made some changes at our facility. You've made changes. We've all been making changes, and certainly it's driven by research. But to see this, kind of body of literature to come together that really is all driven by allied health professionals. There are no physicians driving this literature right now. It's just really going to be answering a lot of questions for everybody. So any final thoughts about how to encourage people to get evidence-based practice going at their own institutions?
I think, as we've talked about already, the key is to get everybody involved. If people get involved, and nurses and allied health professionals get involved in creating and actually, making that evidence-based research, then they will be involved, and they'll be really keen to see, actually, this is something that we've done ourselves, and we've implemented it because and it works, and it's reduced length of stay, it's made the patient recover quicker, and I think by engaging people, that's the way to push it forward.
Thank you.
I totally agree with you, but also a cautionary word. For example, one of my PhD themes is pain management, and we did a great nurse-driven pain protocol created with intensive care nurses, with ward nurses, and we did a pilot study. We had great results with the lowering of VAS scores and then lowering of the amount of time to get patients pain-free. And then I did a follow-up study of 6 years, and then you saw all the effects we had created going down, the amount of measurements being taken going down. So evidence-based practice is very important. If you do implement something excellent, kudos to you, very good, but make sure that it's something that keeps being integrated into your daily activity, that somebody still keeps a finger on it, that it's done correctly. Because after 6 years we saw some detrimental results and we saw some VAS scores going up again. So evidence-based practice, great. Involving everybody, great, but also make sure that it's not finished at that moment. It's not finished when it's a protocol on your computer system. It's never finished. Everybody should keep working on it and keep involving each other in using that evidence-based practice.
And that brings up another good point about really always doing that reassessment.
Yeah.
I know, the big issue several years back was to make sure that patients weren't flat. Everybody had to have the head of the bed up at least 30 degrees, and that had adverse impacts on pressure ulcers that hadn't been anticipated. So, now we have to sort of balance all of those activities, and it really is just sort of monitoring how we're doing after we implement these practices, that we can really see those sorts of issues crop up and make sure that we are always doing the right thing and using the best evidence.
I think that's with evidence-based information. It's sometimes when you look at the information that's out there, every time you find a piece of information that has evidence that's good, you can probably find a piece of information that has evidence against what you're saying. So it's really, understanding the research that's out there, and sort of reading it carefully, implementing it carefully, and making sure that you are doing it right.
And it is never finished.
Never finished.
No.
We have lots of job security. On that note, I think we'll go ahead and wrap things up. It's been our pleasure to present this to you today. I hope you'll get the final chapter of this that we referred to. Once you've done this great work, you have an obligation to publish it, to share your information, and we put together a nice roundtable several days ago on how to get your work published. So hopefully both of these will be very helpful to you, and thank you so much for your attention today.
Thank
Bye-bye.
you.